There's still some back door working. Yeah, we can talk after. All right, good morning, everyone. Thanks for having me back. We're going to talk about EKGs and acute MI cases and anything else you want to talk about related to cardiology. If you got a question, just feel free to interrupt me and we can talk. But I'll try and make this somewhat interactive so that you can all, be a participant. That would be perfect for me because it is 7 a.m. All right, so this is kind of our objectives for you guys. Should be a little bit of rework for some of you. I'd find that relearning how to read this stuff or going back to the basics is never a bad idea. I still look stuff up once in a while on really weird EKGs, or I'll talk to one of my electrophysiology partners about a really bizarro EKG. So there's nothing remedial about going back and kind of reviewing some of this stuff every so often. And I don't want to spend too much time on this because I know you all are pretty familiar with this. You're the first person in many times to contact the patients. So I know you know all this, so I'm not going to spend any time on that. I think one of the things that's been highlighted to you guys, at least by me, I don't know about other programs, is trying to do a somewhat reasonable assessment of patients' comorbid conditions. So when you walk into a house, a site, wherever a patient is, ideally you're kind of getting an assessment of what other comorbid conditions the patient has. If you're walking into a chest pain, what else could the patient have wrong with them? Are they on hospice? To me it doesn't make very much sense when 911 gets called for a patient that's on hospice, but I know that it happens. I'm sure you all scratch your head wondering, WTF, why am I here? But it happens, and I've seen it cause a lot of commotion and create a lot of inappropriate resource utilization because everybody's following the protocol, and that's just what we do. And then all of a sudden we got a 89-year-old with metastatic cancer waiting for some kind of procedure that doesn't make any sense if you look at the whole picture. So looking at DNR status, I know not very many patients have bracelets, but DNR I know doesn't mean do not treat, but it definitely means we got to take a moment and reevaluate the whole situation and not just immediately push the button and send you down the pathway in the protocol. Advanced dementia, if somebody is having an acute stroke, I've only probably seen this once or twice in my life where they're having an MI and a stroke at the same time, but it does create a lot of mess. That is something I would absolutely want you to touch base with your ED docs about. What are we going to do? Because doing a catheterization, at least a cardiac catheterization, on a patient with an acute stroke, that's a relative contraindication. So it's not it doesn't mean I wouldn't do it. It just means I definitely want to know more about this stroke before we go fishing catheters in there. And these other ones, the extremes of age, I think, I wouldn't ever say we wouldn't do a heart cath. Every year I meet a person who I think, gosh, you're not going to have coronary disease. You're only in your early 30s, and then they do. I don't think it means we won't do it. It just means, man, I really want to take a second look at that EKG in this 22-year-old. I really want to take a second look at, this 96-year-old. Let me just relook at the rest of the picture in that patient. You know what I'm saying? So, are you a full code, sir? Do you have any other health problems? Just common sense. But you'd be shocked at how lacking this is. Actually, you probably wouldn't be. So I think these are hard things to teach. I can't teach them to you. You just have to kind of grow into that role. Okay. So EKGs, is it me or is it like turning up the warmth in here. Are we going to get a little sweaty? All right. Anyway, it's all right. No, I'm good. So EKG, this is like a picture of the heart. It's an electrical picture of the heart. This is a wonderful tool we have. Not a lot of other people have it. You guys probably work with neuroscience in terms of acute stroke care and how to do that. They don't have this. You got to go into a CT scanner to get this for them. We have this tool, which is kind of cool. Because it can give us an idea about if there's what's called an injury pattern, and STEMI, ST elevation MI, is an injury pattern that we're picking up on the EKG. Okay, you always want to marry the patient and the ECG. So if a patient is sitting there telling you feel fine, and the top of the thing says acute MI, again, you need to dig deeper. Okay. You need to dig deeper, relook at the EKG, talk to them a little bit more, etc., etc. By the same token, if the patient is sitting there like this, crushing pain, sweaty, and the EKG is totally stone cold normal, it's a reason to do another one, okay? Or relook at it, or do we got the leads on right? I got a consult the other day for an abnormal EKG in my office. Somebody just put the leads on wrong. I mean, it looked like a bad looking EKG, like everything was flipped all around, but it was lead misplacement. So just take another look. And like I said, the initial EKG may not be diagnostic, and this is an evolution, okay? I did a case Tuesday in the middle of the night of a woman who had, from Berlin, who had really hyperacute T waves. She didn't have diagnostic ST elevation yet, but the guy called me and he's like, and I know what the evolution of an MI looks like, right? So initially you get kind of hyperacute T waves, and then eventually the ST segments will come up, and then if you wait long enough and the myocardium dies off, you'll get Q waves, meaning you had an old infarct. Okay, so it's an evolution, but I accepted the activation. Because I knew the guy had seen the patient and it was a good story, and she was just very early in her MI, which is great, right? We'd rather catch it earlier. Okay, let's go to the next one.
I have a question.
Yeah.
How often are we doing like the right side EKG 12 leads and posteriors?
Yeah.
They're in our protocols, and I've probably done them a handful of times this year, but...
Right, the right-sided EKG, to me, for you guys, I don't really see much value add. So, I mean, if the patient's hypotensive and bradycardic and they got inferior ST elevation and it looks like and they're behaving like an RV infarct, I don't really need you to do the EKG to make that diagnosis, okay? We already got a diagnosis from the standard 12 lead that there's an acute inferior infarct. So for you to take the time and move the leads the other direction, I don't know is that much of a value add, because we already have a diagnosis. If they're hypotensive, you're going to treat them with fluids and follow your normal protocol. It's not like you're going to do anything dramatically different in your treatment algorithm. I'm assuming that. I mean, that's the way I take care of it. I'm assuming you would take care of it similarly, correct? Okay. So then the question about the posterior one, I think, is good, because adding leads V7, 8, and 9 does give you a new kind of angle to look at the heart. And if you are thinking, gosh, this guy's got a story, but we're not seeing much on the standard 12 lead, that I think is a value add. So I would, if you're thinking that this could be an ACS and with ST elevation, then I definitely think doing that extra step would be helpful to get the diagnosis. At the same time, I don't know if you've ever seen this, but you can take a standard 12 lead, and if you see ST depressions in kind of the anterior precordial leads, what a lot of people will do is flip it upside down and look at it in the light that way. And then if you see it's actually ST depression in V1, V2, V3, that some people call that ST elevation in the posterior leads. Now, anatomically that doesn't make any sense, because if we're the description of the leads doesn't always match. So anterior and posterior are, in terms of leads, are not exactly in terms of walls of the heart. But it's a quick and dirty way to do it too. I would tell you, if you called me in the middle of the night and said, I got this patient and I looked at the EKG and he's having a good story and he's got big ST depressions anteriorly, and you said, I think this is a posterior MI, I would take that. I wouldn't make you say, no, I want you to put the leads on 7, 8, and 9. But again, it's marrying the story with the, and could it be just anterior ischemia? Yes. But in that situation, the patient probably has a tight LAD lesion anyway, so I'd be okay. I mean, if it's in the middle of the night, I'm going to be a little upset, but, it's just part of the game. So anyway, here's Heather's got the kind of anatomy of the leads. I'm sure you all know this. It's something you have to know. It should be burned into your brains in terms of anatomically where the leads are. And then when you get out into 7, 8, and 9, you're getting out into you're looking at the posterior wall of the heart, which is not technically seen on this. So a lot of patients that come in, my partner will call me and say, I need you to do a cath on somebody. He's got a good story. EKG is normal, but the troponins up. He'll say, I think it's electrically silent. And oftentimes it's a circumflex. So that's what we're looking for with that 7, 8, 9 leads, is we're going to try and look at the circumflex artery, which feeds the posterior wall of the heart most of the time.
So in addition to this, I am working on our protocol to change right now. Basically, our protocol says if our doc in the box says STEMI, you activate. That's not standard practice, so we'll change that once I get Dr. Westfall on board to the 1 millimeter and 2 contiguous leads or more. And so that's where this is really important.
Yeah, and you guys can be better at reading EKGs than that thing. You easily can be. It's not that hard. And you know the clinical story. The machine doesn't. So you don't want to use that up there, because you're gonna overdose, underdiagnose, overdiagnose. It's gonna be a mess. There are some of them that are so easy, none of us are going to miss them. But then there are other ones that there is some subtlety to, that the doc in the box automatically calls, and then there are other ones where it's there and it's just not seeing it. So it would be much better. I would much rather have you guys interpret the EKG and marry it with the clinical story than have some computer algorithm just spit it out. Okay, so like anything in medicine, you have to have a process for how you interpret this stuff. So if you talk to a radiologist, how do they read x-rays? They do it in a way. They go through like a checklist, okay? Like your trauma patients. So like I have a checklist that I look at in chest x-rays, because if I don't, I will miss like stupid stuff. Like I don't look at the bones very much. So I always have to remind myself in the process to look at the bones, because I'm not an orthopedist. I look at the heart and the lungs. Same is true with EKGs. So because if you just jump to the MI, you may miss something else. So you want to look at the rhythm and the rate for sure right away, okay? And the way I do this is I do rate, rhythm, access, and then I look at chamber enlargement, hypertrophy, and I look at the ST segments kind of last. But you don't have to have the same pathway as me, but I would absolutely say you have to look at the rate and rhythm first. That should be step one, and try and define what it is, and then start looking at the other stuff, okay? Because you don't want to miss heart block in the context of an MI because you were just paying attention to the ST segments, and now your patient's bradycardic and you weren't prepared for it, okay? So it's real important to have a process. So this is the kind of evolution of a acute coronary, of a ST segment elevation MI. Typically this will generate, kind of hyperacute, narrower, peak T waves. They can even invert. Dr. Walsh, one of the ED docs at Appleton, there's a term called Wellens T waves. It's, doctors name things after themselves because we're arrogant. And so Dr. Wellens named these T waves after himself. But that's kind of reflecting, that kind of injury pattern. And then eventually you start getting this pushed up ST segment elevation, and then eventually it'll evolve into Q waves if you have like a complete thickness infarct. Okay, you can go to the next one. Yeah, so here's the ST segment. You really gotta know where the ST segment begins and ends, and you really want to look at it relative to the rest of the EKG. So, look at your QRS. Sometimes these can be tough, especially if you have like a widened QRS. If you have a right bundle, I see this missed a lot. So there's a right bundle and the QRS is wider, and it's hard to tell where the ST segment begins and the QRS ends. Think about a right bundle in V1. You get that RSR prime, and so you got two R waves. It looks different, and so it can be difficult. I don't want to say this is always easy, but if you take a minute and go through that in your head and acknowledge, okay, I got a wider QRS, I got to take a little more careful look here. This is not a quick and dirty, normal, done. When I read EKGs, at night on my computer for our office, the ones that are easy, I can churn through super fast. But then I can just like kind of glance at it, and know, okay, I got to take a minute with this. It's going to take a little bit longer. So, how the ST segment elevates is different, in different conditions. This can be kind of a clue. I wouldn't necessarily use this as an exclusion or an inclusion, but if the ST segment kind of has a frown, or they talk about concave or convex. If it's kind of a frown, that's bad. They say that's an injury pattern. Where if it's more kind of upright, it's more of a smile, then that's less likely an injury pattern. There are people walking around who are well people who have kind of what we call J-point elevation or repolarization changes, and they can look like, some of them can look like an injury pattern, and they just walk into your office. It's great when you get an EKG on those people beforehand, because if they ever come in with chest pain, it's always confusing about what to do. But those are called early repolarization changes, and there's a handful of healthy people walking around, probably a couple people in this room, who have early repolarization changes. And there's not, it just makes it more confusing if that particular patient does have a heart attack or chest pain, because it can look like a diagnosis of STEMI when they just have J-point elevation. But that's when you want to use the other things that you look for. You want to look at, what do the ST segments look like? You would look for reciprocal changes. So if somebody has ST segment elevation and they have no ST segment depression, so remember, the EKG is an electrical picture of your heart, and we're trying to look at all the walls, and the leads look at the walls differently. So some vectors are I don't want to get too much into physics or electrical engineering here, but some of these vectors are this way, some of them are this way, some of them are this way. So the different vectors are looking at the same thing from a different angle. So if you see ST segment elevation in some leads, other leads will view that as ST depression. So when you see that, okay, this is more indicative of an acute MI. Does that make sense? Okay. So reciprocal changes, and that's what we're talking about. Okay. So inferior wall, most of you know this. We're looking at limb leads 2-3 in AVF, and that's typically the right coronary in about 90% of us. Okay, the inferior wall is perfused by the circumflex in a small percentage of us, and that just refers to dominance. So if somebody's coronary circulation is right dominant, that means the inferior wall is perfused by the right coronary, If they're left dominant, which it's much less common, the inferior wall is perfused by the circumflex. So sometimes you'll have an inferior wall MI that's a circumflex, but most of the time it's a right coronary artery. Okay, next slide. Lateral wall. So again, this is an anterolateral infarct on this EKG, I'll tell you, because you got big ST elevation in V2. But the lateral wall, again, the circumflex, V5, V6, this is where you might consider that V7, 8, 9 leads, and typically that is supplied by the circumflex. Although in some patients, they can have a tiny circumflex and a ginormous right that gives off a ginormous posterolateral branch and feeds the whole lateral wall. It's just how you build your highways when you were a fetus growing up in your mother. But I mean, most patients, the lateral wall is the circumflex. You're going to look at V5, V6. You're going to look at limb leads 1 and AVL, and sometimes it's tough. And you may want to look at 7, 8, 9, or you may want to look for those ST depressions in V1, V2. Okay, next slide. All right, so let's talk a little bit about things that are mimickers of heart attack that are pretty common. And just a couple days ago, we had an activation in a dialysis patient, and I was actually at another hospital. And I heard the story, and I told my partner, go look at this. I guarantee it's hyperkalemia, and it was. So, I mean, it's so common. I'm like, God, why don't they just wait and get a potassium? Because, end-stage renal disease, you guys know this. Anyway, but they don't, and they activate. Okay, so the common things, left bundle. This is difficult. I'm not going to lie. This is where communication with your hospital that you're sending patients to is key, and you probably want to talk to the ED doc about, does this patient have an old ECG? Pericarditis, again, it's a challenge. You often see ST segment elevation, however, you don't typically see reciprocal changes. And a couple things you can see are like PR depression. These are subtle findings, but they can sway you. And again, the story. So yeah, 2 weeks ago I had fevers and chills and a terrible body rash, and and now my pain hurts if I lean forward or take a deep breath. So geez, that doesn't really sound like ACS kind of symptoms. Okay, next slide. Okay, so this is the left bundle. You guys know how to recognize this. So a QRS duration over 120 milliseconds is the rule. There's no reason for you to remember that. Some people call 100 to 120, incomplete left bundle. The pattern is what you want to see is, the negative deflections in V1 through V3, and usually an upright in limb lead 1. Those are the ones I look at. A lot of people will be concerned about, I don't want to yank her, V6, oh yeah, perfect, thanks. That way I don't pull your thing off the, people come about being upright in V6, don't worry about that, just look at the pattern, downward deflection here. You'll notice that this looks very similar to what a paced EKG looks like, okay? So most pacemakers are in the right ventricle, so if you pace from the right ventricle, it creates a left bundle pattern, right? Because you're activating the right ventricle first, as if the left bundle was out. So this can be easily confused with a paced EKG, which is another very difficult situation. We cannot interpret that EKG very easily for ST segment elevation. In general, you guys know the rule, a new left bundle would be an ST elevation equivalent. I will tell you, it's a challenge sometimes. Patients might not know, oh yeah, I have a left bundle branch block. They won't be able to tell you that. But you should ask. Like, some people do know. And they'll say, yeah, no, I've had that. I tell my patients who have it, you have this, just FYI. And, a lot of them know it, but some of them don't. And if it is truly new and they have a good story, then it should be treated as a STEMI, okay? If it's new, good story, STEMI, okay? Now, a lot of times it'll be hard for you guys to know if it's new, but do the best you can. Pericarditis. So, again, we're looking at ST depression, often diffuse. And then the other thing we often see is PR depression. And this positional component to the pain is really helpful. So if you're seeing a patient who says, yeah, it hurts like hell when I lean forward or whatever, think about pericarditis, okay? And the fevers. Hyperkalemia, if you can imagine just taking your EKG like it's all on a string, okay? And if you can imagine, you just kind of pull the string. And if you ever see a really bizarre looking EKG, just think high potassium, okay? It'll often be kind of splayed way out. You look at the bottom one here on the left here. This is hyperkalemia. It gets kind of pulled out. It looks really weird. But initially, you kind of get these peak T waves. But you can get ST elevation in the context of this, or sometimes people will call it VTAC or a slow VTAC. But it's all, dialysis patient. If you ever, I don't know if you guys have to take recertification exams. I took my general cardiology recertification a year ago. It's on there still. And it's always in the stem of the question, and they give it to you, a dialysis patient. So think about it, okay? And J-point elevation we talked about. It's tough. This is not easy, but they get this kind of upright ST elevation here. It's concave, so it doesn't have the frown. And it's in young, healthy people, and they're walking around with it. It makes it harder to interpret their EKG. There is a lot of research going on about, is there anything unusual about these folks, or do they have more arrhythmias in the future? And the answer to that is probably yes. They do have a little bit predilection for arrhythmias. What we do about it and which ones present with it, I couldn't answer that yet. Okay, next slide. All right, so let's do some cases quick.
So for all cases since I've started.
Perfect. All right. So I'll read the stem, and then you guys are going to read the EKG. Deal? Okay, 71-year-old male, substernal sharp chest pain, shortness of breath, nausea, vitals are normal. He's a DNR. So, are we going to activate? No. Good. Doesn't mean we won't activate, it just means we're not going to do it right away, okay? Because he's a DNR, we need to get more information. But let's look at the EKG. So who wants to read the EKG? Remember we talked about the process of reading the EKG. So what's the rhythm? Okay, so somebody said it's regular, okay? So that's good. That's an auscultatory finding, right? When you tell me, I examine the patient, he's got, regular rate and rhythm, okay? That's good. Now, you can have a regular rate and not be in sinus rhythm, right? You can be regular and not be in sinus. So when you're describing the EKG, you have the ability beyond auscultation to tell me the source of the rhythm. So in this situation, it's a sinus rhythm. And the reason we can tell that, and this is not an easy one, you want to look around here, but you can see pretty clear upright P waves in the inferior leads. Inferior leads are going to give you the P wave morphology you're looking for, and you're going to want to say, is it upright or is it upside down? If it's upright, it's probably from the sinus node. Okay? So you would say this is sinus and the rate. So each one of these boxes you guys can learn, these go this goes to 300, this rate is 150, this rate is 100, so it's about 100. So maybe sinus tachycardia. And then what do you think about everything else here? What do you think about ST segments? What do you think about everything else? Say that again? Yeah, so the patient's kind of got ST elevation in V1, V2. They got a little bit of ST depression out here and in the inferior leads. So I'd be concerned about, now there's something else going on here that's a little bit different, and that is the QRS duration is not normal, right? It's kind of wide. I can't see the tiny boxes here, but whether this meets criteria for a true left bundle, I don't think it does. It looks more like what I called an incomplete left bundle, But there is concern for me here in terms of injury current in V1, V2, and then I got some concomitant ST depression in other leads, which would make me think, yes, this could be a acute MI. So I would have, if the story's good, he's got shortness of breath, nausea, and chest pain, although he's a DNR. So I would want to talk to him more. I wouldn't fault anybody for activating this in an appropriate patient. All right.
Nitro, aspirin, Brilinta, pain resolved. Second EKG was done.
Okay. So they did another EKG here, and you can see the ST.
That's right over there.
Oh, this.
That one.
Oh, we're
That's
still
the
here.
second one.
Oh, okay. All right.
Yep.
Okay. So aspirin, pain resolved. Second EKG is done. Okay. So now the ST segments are still there. The ST segment elevation is still there a little bit. He's still got ST depression over here. It's definitely better over here. Still in sinus rhythm. Pain resolved now. In this situation, in a DNR, I'd probably sit tight. Okay. The reason I would is because the ST segment in this V1 and V2 with a widened QRS and incomplete left bundle is a little bit wonky. So I wouldn't be. I mean, if this was a little bit more convincing on the prior EKG. Now, if the patient's still having pain and he's willing to go through a cath, he's willing to rescind his DNR, we're good to go. I would take him to the lab. But if he's pain-free, I might sit tight for a little bit, especially in a DNR patient.
So yeah, this patient was canceled, capped the next day, acute lesion in the vein graft to O1, stent placed, and discharged the next day.
Yeah.
Can you talk about when we bring a patient in because we see ST elevation, we think MI, but then it gets canceled. Sometimes they're like, oh, I swear I thought that was right.
Yeah.
And you may have been right at that point.
Yeah, so this wasn't wrong. So if somebody activated this, I wouldn't have been like, oh, what a mistake. I will tell you, STEMI in people with prior, we didn't know that he had prior cabbage. I'm assuming you guys would have opened his shirt and seen that. I will tell you, STEMI in people with prior cabbage, not quite as common because you got multiple pathways to get to the coronary circulation in a lot of instances. Now this guy had an acute lesion in the vein graft to the OM. We don't know the rest of the anatomy, but not as common. Usually when I hear, oh, they're post-bypass, they had 4 or 5 grafts, and they're like, oh, it's a STEMI. Number one, that just made my job a lot bigger pain in the ass. So, because we got to go fishing for these old vein grafts, which may or may not be marked. So it's always more difficult. Secondly, it's just not as frequent because there's multiple pathways. So, but this is not a wrong activation. That was an ischemic-looking EKG. We could go back and forth about whether it was a true current of injury with a diagnostic ST elevation. I absolutely think the first one was, but if the guy wasn't activated because he was a DNR, I'd be fine with that. Give us a chance to have a conversation with him. If the guy came in and said, I want everything done, and he's still having pain, I would have brought him to the lab. Absolutely. I'm not surprised he had an acute lesion based on that EKG.
And it's EKG that they did wait because when they're pain-free and the ST elevations resolve.
Yes, this EKG looks better, and the guy's feeling better. So the opportunity to get some medication going should not be dismissed. So just because we didn't go to the lab immediately, you got to understand, going to the lab immediately is great when, it's absolutely the right thing to do, but there are opportunities that we don't gain by doing that, and one of them is getting the appropriate anti-ischemic, anticoagulation medicine going, and then cathing that patient with, after they've been on IV heparin or oral antiplatelet drugs or IV antiplatelet drugs can often make the case much better and less risky. So, rushing in right away on a patient who just had a pizza, you can understand there's a little bit more risk of that. So we have to think about that thing. And in this guy, I think it was very reasonable to wait based on this EKG and knowing that V1, V2 with a widened QRS, a little bit wonky, and now we got him pain-free. I would have been very happy to sit tight, especially if this was in the middle of the night. Okay. Oh, is it? Okay, here we go. 71-year-old male, MD office, indigestion, chest pain. MD did EKG and called 911 for transport. Okay. So, who's going to read this one?
Because they're tired.
Medic 5 didn't do anything. Jody answered.
Jody.
All right.
Breathe good.
So yeah, let's talk about a couple quick things.
What's regular?
It's regular, okay.
Sinus.
Looks sinus, very good. So the P waves are upright, and the rate is it normal, Brady, or tachy? Normal. Yeah, it's sinus rhythm. It's not Brady, it's not tachy. Okay. So let's take a look at other things. I mean, you got to have a pathway. So for you guys, I'd probably say once you get the rate rhythm, start taking a look at the ST segments because you're trying to make a quick diagnosis acutely.
V3 has some elevation. V4 has some elevation.
Right. Right.
2, yeah, but you can't see all the little boxes. So is it enough? Like, is it a millimeter to
Yeah.
consider it elevated?
Yeah. So these two in particular to me
Yeah.
look a little bit more concerning. So V3 and V4. Now, if we look for the thing that we often try to look for with ST elevation, which would be reciprocal changes, that's the one thing that's kind of we're not seeing over here. And usually with an anterior MI, you'd see inferior reciprocal changes, but we don't. So this guy I would be concerned about, and I think if he's got chest pain. He doesn't have reciprocal changes, but not everybody does, okay? And I would tell you, if this is truly a STEMI, we're pretty early. We kind of got that peaked T-wave thing looking over here. The T-wave's more than 2/3 of the QRS. You don't have to remember that. I'm just saying that's a way that I look at it. Is the T-wave too much? And I would say yes. So if somebody activated this, I'd be more than happy to cath this gentleman. Okay, next one, Heather. What happened to this guy? Oh, now he's in the 90s. He's worse. And now this is looking, what do you guys think? Any changes here? We got some artifact in here and in here, which makes some of the issues a little bit more. But we definitely have, I mean, depending on, and sometimes you can look at V4 and there's 4 beats of it, right? And like 2 beats have ST elevation and 2 don't. So what do? Flip a coin? I mean, it's difficult. So, I mean, if you look at this one, this one clearly it looks a little different than this one, right? I mean, so he's still got ST elevation here. I would, personally, I'd still move forward with the diagnosis at this point. Although, again, he still doesn't have... Who would activate this? Yeah, I guess I already said I would, so...
First EKG.
Yeah,
And you would, okay. So we didn't activate this.
we did not
We
activate
did not
it.
activate this.
Okay. Decompensate and decline. ED activated code STEMI, 100% LED, 2-vessel PCI. Okay. So,
So this was a miss.
this was a miss. This was early in the evolution of the MI. Okay. But you saw it in V3 and V4. It was there. It just didn't hit you over the head, and there wasn't major reciprocal changes. The guy didn't have a lot of voltage to begin with. If you look at that EKG, there just wasn't much in the beginning. So just those are the subtle ones that are not easy, but I think you all saw it. It was there. It just wasn't one of those obvious hit you over the head ones. Okay, next case. 70-year-old gentleman, chest pain while doing yard work, history of heart attack 2 years ago, pale and diaphoretic. Okay, so let's start from the beginning. We'll go with the right side of the room. What are we calling the rhythm here? Sinus. Fast, slow, or normal? Normal. Good. Okay, so it's not Brady, it's not tachy. Okay, so now, do you see any injury current? I hear a lot of so a couple things. The QRS is a little bit wider. You can almost see like what looks like kind of a left bundle thing looking over in V6. It's not wide enough to call left bundle. One of the things I look for are evidence of an old infarct, and we talked about Q waves, right? So you can kind of see evidence of Q waves, and he has a history of a heart attack 2 years ago. It's in the stem. So when you see that, the guy say, yeah, I had a heart attack. Look and see, does he have any old Q waves? And you can see here he does in the inferior leads, which would suggest he had an old inferior infarct. So my question now is, do you see evidence of ST elevation where you would activate an MI? No, okay. There are some subtle changes with the ST segments in the inferior leads here. Subtle, okay? I would say it is not diagnostic for a STEMI. I would not activate. I will tell you that when they've had an old MI with Q waves, sometimes that can create some changes in the repolarization as well. So you might see some old kind of residual ST changes. But this one I would not activate as a STEMI. Okay, STEMI activated and canceled. Cath the next day and received a stent. So I would agree with the cancellation. Just because they were cath the next day and got a stent doesn't mean we should have done the activation. Okay, doesn't mean they should have been they should have gone immediately to the cath lab. Going immediately to the cath lab is not always the best pathway. So yeah, I would not have activated that. I think whoever did was looking at those inferior leads and maybe seeing more than I did. I did not see one box of ST elevation. And if you would have acknowledged that there was a Q wave there, it would have heightened your awareness that I got to be careful here because there's already been an infarct in this territory. Does that make sense? Okay.
I have a question about that one as well.
Yeah.
So when you cancel them after we brought them in and then they're capped the next day, is that because their blood work showed like elevated troponin throughout the day?
Yes. So oftentimes that'll mean we took the time to do a more thorough evaluation. So we did further EKGs, we did serial troponins, we saw what happened to the patient. Yes, but that you can still have a ACS or acute coronary syndrome and not have a STEMI, right? There's other disease. You can have unstable angina, you can have a non-STEMI. Those do not need immediate catheterization, okay? They don't. There's no medical evidence to support that, okay? Early revascularization, usually within 24, 48 hours is the pathway we send most of them down. But think about it. If you bring somebody in and we don't know anything about them much, and we got to rush in there and do a catheterization, many times I don't know what their hemoglobin is, I don't know what their creatinine is. I mean, wouldn't you want to be able to have that information before you would invade somebody? Like, what if the hemoglobin's 6? I mean, this has happened, and they've been activated. You guys don't know, but, once we activate, not everybody, the really good people who participate in the care of the patient think critically, but some people just put their head down and we're going down the pathway, okay? Heather's got videos she can show you of cartoons of, ED docs and cardiologists fighting about this, and, it's a STEMI, so we're going down this pathway. Well, just stop and think critically for a moment. The patient's pale as hell and, has had melena for a month. And then, all of a sudden we got a hemoglobin of 6, and I just put a stent in them, and now they need dual antiplatelet therapy. Now I got a mess. So if we have the opportunity to take the time to get more information, we would absolutely prefer that. And it's not to not take care of the patient the right way. We're absolutely taking care of the patient the right way. Okay, so 34-year-old male, non-radiating chest pain, difficulty breathing. No cardiac history. He's lethargic and distress. Weak pulses, clammy and diaphoretic. Okay, so let's take a look at the rate and rhythm. Brady, good. Rhythm? Heather picked real easy ones for you.
The Q wave's not really discernible,
Yeah.
so it's hard to...
Yeah, there's probably one right there. Probably one there. So in AVF, it's a little bit easier to see. So I'd say this is probably sinus Brady. But I agree with you. It's not easy to see the P waves. Okay. Anything else interesting about this EKG?
Diffuse depression.
A lot of ST depression. Elevation and AVL, yeah. I mean, that's a great pickup, because if you miss that, you might not activate this patient, right? Because they got global ST. Another interesting thing to me is, I mean, think about it. This guy's having chest pain. He's lethargic. He's hypotensive. I mean, when do you meet a 34-year-old who's hypotensive and their heart rate is this? That's weird, right? So when you're going through your algorithms in your head, which I'm sure you would be, about what's the differential of shock, you know, you guys know this, but septic shock and, you know, systemic allergy, distributive shock pictures, they don't present bradycardic usually, right? They're tacking away. So something's wrong here. And I will tell you this right here. So AVR is kind of like the bastard stepchild of EKGs. We don't look at it that much because it doesn't really fit in one clear pattern. But if you see, if I get I can think of probably a couple times in the last couple months I've gotten consults from docs and second opinions, and nobody looked at AVR on a stress test. And I will tell you that if you get some changes on AVR with a stress test, that's kind of an ominous finding. But a lot of cardiologists don't look at it. But this would concern me a lot. I mean, the whole EKG worries me. Okay, I mean, there's no question in my mind. There's something bad going on here. This ST elevation and this global ST depression. I would absolutely activate this patient. Okay.
And Dr. Gibson does all these cases, by the way, because they're a mix of Ascension and Data Care and not his. A lot of them are not. I don't think any of them are yours.
Okay.
So.
Okay. Aspirin, code STEMI activated, fluids and Brilinta not given. Good. That's fine. Unable to attain blood pressure. And now look what we're doing here. We got a little bit more clear picture. It's almost like he's developing. Well, over here it looks like his QRS is kind of widening into a left bundle pattern. You still see ST elevation in AVL, lots of ST depression inferiorly, and this our bastard stepchild lead here is really beating on the door and telling us something is wrong. So and then you can see ST elevation here and here. So we got to go to the lab with this guy. There's no question.
It's a lady, by the way.
Oh, sorry, woman.
Just assume it's a guy.
Aortic dissection. Yeah, that's too bad. That's too bad. The great mimicker is what dissection is called. She, if I had to guess, most of the time the dissections include the RCA, but
Were there comorbidities on this patient? Like, was there a family
No.
history or anything?
34, really?
34-year-old female.
So I agree with. So there probably was. I have a handful of aortopathy patients that I follow. So disease of the aorta, they, a lot of them have connective tissue diseases like Marfan's or Ehlers-Danlos or Louis-Dietz. These are congenital inherited diseases where even if you have a little bit of enlargement of your aorta, you're at high risk for dissection. I have one Marfan's family I follow. And Marfan's disease is not all Abe Lincoln looking people. I'm just telling you. The woman who is the index patient, then I follow her family, she's Hispanic and like this tall. So it's not everybody looks like Abe Lincoln, and you can use that. And there are the nice part about Marfan's disease now is there are send-off tests for fibrillin gene mutations, and you can get them genetically tested instead of going through this stupid criteria of having people go like this or measure their fingers or all that crazy stuff. So anyway, I digress. I did have a dissection case 4 months ago, and it was a woman who had a prior cardiac surgery. She's probably 68 years old, 70, and I put the catheter in her ascending aorta, and it didn't feel right. I can't explain it to you unless you've done 10,000 caths, but it just didn't feel right. So I didn't even do the cath. I just pulled everything out, and I'm like, I got to do a CT scan of you. And this was at 8 o'clock at night. It was such a pain. But I took her down to this CAT scanner at Theta Care, and she had a ginormous dissection. And actually, Abuzlan was on call. He came in and did her. She survived. She's doing great. But it's very difficult diagnosis to make. Like, I was in the lab shoving catheters in a place where they did not belong, and but got lucky. All right, 80-year-old female, facial droop, right-sided weakness, slurred speech, EKG done per protocol. Okay, let's read the EKG. So rate rhythm, what do you think? Okay, so sinus, it's not fast, it's not slow, it's normal. Okay, ST segments, anybody seeing anything here that they would activate? No. Okay, so the doc in the box is reading STL, is reading acute MI. What it's seeing here is, and this is not unusual, and this is why you want to make sure you do, is that it's seeing poor R wave progression. So you guys remember the QRS complex. Q wave is your first negative deflection. R wave is your first upright deflection. Usually you see this transition of what we call R wave progression, where the R wave kind of grows. It's not very much in V1 and V2. It's like 50-50 R wave, S wave in V3, V4. And then by the time you get over here, V5, V6, it's mostly upright, right? R wave and then very little S wave. Well, this is not that way. So sometimes this pattern can be seen in somebody who's had an anterior MI, meaning they lost their R wave progression. But, there's definitely no ST elevation here. I would not activate this. You could say on the formal read, abnormal R wave progression, consider remote anterior infarct. But sometimes I see this, and it's just because the patient's heart is tilted a little bit more. In an 80-year-old, she probably has a little bit of shift in her heart from long-standing hypertension. So we may be missing the R wave progression electrically just based on where we put the leads. So this is not a STEMI on the EKG. It damn well better not be activated based on this, right? You got all the symptoms in the world of a TIA stroke. So again, not a situation I want to be putting catheters in. So hopefully we did not. Okay,
so we repeated, which.
Okay, repeated
awesome.
it. Yeah, good move. So again, okay, otherwise read. Activate or not?
No.
Good. I would not activate this. Okay. Called report, diverted to TCA, aspirin, activated code stroke, had acute stroke. Perfect. Well done.
Could have been. I made this a long time ago. A month ago.
Okay, let's go to next case. Okay, 84-year-old sudden pain that woke her up, nausea, radiation to the left side, no cardiac history. Here's our ECG, aspirin and nitro given with improvement. Okay, so go ahead and read it. We'll go in the middle of the room. Sorry, I just lasered you all.
Been in the type 1 rolling at 441.
Yeah. So, what do you think? The rate, is it fast, slow, or? So it's not fast, it's not slow. What's the rhythm?
Is it AFib or is it a sinus arrhythmia?
Yeah, this is a tough one. Heather didn't pick easy ones. I'm looking in here for P waves. This lead, I kind of convinced myself that I could see some. These leads, it's hard. In V1, this for me looks kind of like AFib over here. So I don't know if the patient has a history of AFib. I'm really not seeing much over here. There's a lot of, I don't know if you guys were going over a lot of bumps at this moment when you were getting your EKG. But yeah, I would say, possible AFib, but I would need another EKG another time to make a firm rhythm diagnosis. Let's go back though.
Oh, I'm sorry.
So ST elevation, yes or no? Would you activate, yes or no? Middle people.
Say it again? Yeah.
Would you ask?
Activate or not?
No.
Okay. So I want you to look here. V3, V4, and V5. And these portions here, I think we have ST elevation. Okay? So I would activate this.
I'm sorry.
Oh,
We're not here to be punitive. She said, Paul, you suck. I think. Anyway. All right, let's go ahead.
There you go.
All right.
No excuses.
Okay, code STEMI activated, pain remains. Now, I think it's a little more clear in terms of we're not riding in a bumpy road, I guess. So what do you guys think about the rhythm now? Okay, you just gave me a descriptive diagnosis of your auscultatory findings. Tell me what the rhythm is. AFib, very good, very good. AFib, okay. Yeah, a little bit of a right bundle pattern. You got kind of a probably an incomplete right bundle, but I agree with you. What about the ST elevation? Not as much. Yeah, it's definitely looking better. I agree with you. It's still there a little bit in V4 and V5. She still has pain. I would still go based on the original ECG and activate. Case canceled. Admitted to hospice. Okay.
Like I said, he didn't know this. This is kind of cool.
Yeah, this is kind of cool. Not so much anymore. So I didn't know about the hospice. That would have been interesting to know what comorbid conditions.
This patient to hospice.
Oh, okay,
After.
okay, okay.
Because which I think is huge that you guys don't have advantage of the ED and chronic changes.
Yeah, yeah. I mean, I definitely was V4, V5. I would have not faulted you for activating. Usually people aren't admitted directly to hospice, so I'm guessing there's a little more to the story in this 84-year-old. Yeah. If this was one of my relatives, this might be how I would have gone, but okay. 37-year-old male, I guess this will have to be my last one. Not acting right, called by patrons, was diaphoretic, grasping his chest, and complaining of palpitations. Admits to using meth the night before. Who doesn't? And so here's our EKG. So, what do you guys think? Sinus tach, I agree. Good. Anything else?
Maybe some depression interior, like 2, maybe 1, 2, 3.
Mean V1, V2? Okay. So I want you to ask yourself what else is going on. Is the QRS normal?
My values are up.
No, but
Your what is up? Oh, okay. Sorry. So what's unusual about the QRS? Right bundle. It's wide. Okay. So it's a classic right bundle pattern. The rabbit ears in V1. So again, it's going to make it more difficult because your QRS is kind of splayed out for you to read all the ST segments. And that's kind of, in my mind, what's creating some of what you're seeing here with the ST depression in V1 and V2. Does anybody see ST elevation?
Is there any AVRs that just meant?
Again, remember, you have a right bundle here. So some of what you might be seeing as ST elevation could still be the QRS segment. And in this situation, I think it is. I don't see any ST elevation. I would not activate this. But I don't know if they, oops, sorry. So STEMI was activated. Aspirin given, Brilinta not given. Repeat ECGs done. Okay, so now what's your diagnosis? Math. Is that a diagnosis? You guys would know better than me.
sorry, Menashe.
All right. So this is being recorded. So we have sinus tach again and right bundle. I don't see any ST elevation. Definitely. Again, this is an example of the age things. Like, do you see many 34-year-olds having MIs? No. And he's got an abnormal finding on his EKG. I agree it's not normal. The right bundle makes it a little harder. In combination with the tachycardia, makes it quite a bit harder. You can see he's slowed down a little bit on this EKG. It makes it a little bit easier to read. I would give this guy some fluids and maybe get another EKG. I definitely would not activate this. Definitely. And you do not want to give this guy anticoagulation, right? Okay. Cancel discharge with drug use and tachycardia, right? Okay. All right. unfortunately, I do have a patient at 8:30, so I can't keep doing cases, but I'm happy to come back another time if you want. Again, the highlights I would try and get you all to remember are have a process for how you read the ECG, okay? Get the rate and rhythm before you dive into the rest of it. And if you have to take some time to do that, that's okay. And then think about marrying the story with the EKG, because that's you're the provider at that moment. You know, don't just look at the EKG, and think about what the mimics are that Heather's talked about, that I've talked about, and how those might appear, and what you would do with that information. So a left bundle, we're going to call ahead. Pericarditis looking EKG, I'm going to ask some more questions. Early repolarization, I'm going to look, is this guy, 25 years old and no cardiac history. Extremes of age, think about that. So really old, and really old's getting up and up and up and up now, okay? So, but, I think of really old as kind of 85 plus. I mean, ask a few more questions. Look for a DNR bracelet. Really young, ask a few more questions before activating. Just use, the 52-year-old male smoker who, those, with obvious, you guys are going to get those. It's the subtle ones, and that's probably half or more of the activations. There are some that are chip shots, I'm not going to lie, and you'll all get those. But it's the other ones where you want to be a little bit more discerning. Let me ask a few more questions before I hit the button to activate. Maybe I can do a STEMI consult. I know ThedaCare has it. I'm going on St. E's Pulsera next week. I don't know if they have the consult feature.
I'll talk to Becky.
Anyway, so that's what's going on, and those are the things